Morning, everyone. Thank you for joining PHCA for today's webinar on falls management. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number when registering. I'll be sending a link to a quick survey. Your feedback is very important to us and to our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit your questions using your questions pane on the right hand of your screen, and our presenters will address them at the end of the presentation. Now for today's webinar. This webinar is being presented by Angela Edney, National Clinical Director, and Kevin Brogley, Clinical Practice Specialist, both with Aegis Therapies. Falls are a significant risk to the elderly population. There are many negative consequences of falls. It takes a team approach to implement a comprehensive falls management program. Cognitive impairment and low vision are 2 major conditions that result in a higher incidence of falls. This webinar will present a proactive approach in fall prevention by focusing on how to accurately identify and assess these 2 common conditions and provide specific strategies for implementation of a successful fall management program. I'll now turn the webinar over to Angela and Kevin.
All right, thank you, Wendy. And thank you to everybody attending today's webinar, A Collaborative Approach to Falls Management. We hope you will find today's presentation helpful in an area that can be very challenging to address in long-term care. So once again, just to give a little bit more background, again, my name is Kevin Brogley, and I'm a clinical practice specialist for Aegis Therapies. I live just outside of Pittsburgh, and I've been practicing occupational therapist for over 20 years, all in long-term care settings. With me again is Angela Edney. And Angela, can you please introduce yourself?
Oh, I'm a national clinical director. I've been working with Aegis over 26 years. I'm an occupational therapist by background, and I live in sunny Florida. Thank you all for attending.
All right, thank you, Angela. And with that, we will go ahead and get started. So I just wanted to cover some of our objectives today. Again, we hope that everybody on the call will be able to recognize major components contributing to falls of risk in the elderly population. We want to describe the interdisciplinary and transdisciplinary team with the implementation of a comprehensive falls management program. And we hope that you guys will be able to articulate a specific fall prevention strategy program for elderly clients displaying 2 of our very common conditions, which are cognitive and vision impairments. Our agenda is really sort of big on the transdisciplinary approach, so it's really just that ability to work interactively amongst disciplines to reduce falls. We'll talk a little bit more about that at the end of where we talk about the program development. I'll start off with some facts about falls. Angela will talk a lot about falls prevention for patients with cognitive impairment and visual deficits. I'll come back and describe how we develop a comprehensive falls prevention program. I'm talking about the team roles and the steps to follow. We will talk about how we can involve recreation activities based programming with falls prevention. And we'll talk about facility-specific planning. And we'll do our best to accomplish all of this in 1 hour. This is a lot of information, so we will mostly be touching on it, but hopefully you will still find this really, really helpful. Okay, so let's get started with some statistics for falls and some of the risk factors. One of the, as you can see, the primary one listed is medications. And what we know is 4 out of 5 older adults take at least one prescription medication daily. 33% of the older adult population take 5 or more each day. And we have to start to look at ourselves, especially as long-term care providers. Are we looking at ways to reduce medications when appropriate? Are we looking at some of our non-pharmacological strategies, such as therapy for pain and spasticity, and getting away from some of those pain medications that can cause a lot of symptoms such as drowsiness and decreased alertness? We also know falls are the most common cause of traumatic brain injury. And some of the risks that are listed on this slide talk about lower body weakness, vitamin D deficiency, gait and balance deficits. One of the topics for today we'll be focusing on is vision problems, considerations of poor footwear and foot pain, household hazards, anything with the environment, and assistive devices or improper use. Pets are a big risk for falls, and then cognition, which again is will be our secondary risk factor we'll spend a lot of time talking about today. This slide talks a little bit about some more statistics for falls. 1.3 million people resided in nursing homes in 2017. At least 50% of the elders in nursing homes fall at least once annually, which is 2 times the rate of community dwellers. And 1 out of 3 will fall 2 or more times. 1 in 10 have a serious injury related to a fall. 65% or 65,000 will suffer hip fractures, and those without the injury often develop a fear of falling, leading to a self-imposed limited activity. So really that fear keeps them participating in other activities, which then leads to further weakness, further debility, and more social isolation. It becomes a vicious cycle. So let's talk about some of the risk factors, and there are many. What I would like to point out here is that there are some that are extrinsic, which are those external factors, and then there's the intrinsic ones, which are the factors related to a person's condition. And what you can see when you look at some of these lists, they can become complicated if you have an extrinsic and an intrinsic condition. So for example, if you have a floor has been mopped and there's wet, slippery surfaces. So that's an extrinsic factor that could really relate to a fall. But if you have somebody that has vision deficits, where they can't see the slippery, the wet floor sign, or they can't see the glare indicating that it's wet, or if they have a sign there and they can't read it because their cognition has went down. So it becomes much more complicated when you look at the extrinsic factors and the intrinsic. So again, there's a whole list. I'm not going to read all of them for the sake of time, but these are things that we would want to consider when we look at looking at falls reduction. So how can we mitigate the risk? The first thing is understanding the disease and the disease process. Angela will be spending some time talking about some of the differences between different levels of dementia and different types of visual impairments. Understanding the person behind the disease is also very important. And I will share some tools in a couple of slides to explain that. But we need to understand really what the person is like. I mean, if we think about a person that perhaps their whole life worked on a night shift, or they're a farmer that got up super early, those are things that could be helpful to know, that behavioral patterns that have been ingrained in their whole life can result into some fall risks that we need to consider. And all of this combined is then really determining the person's best ability to function in the environment that they can most function most independently. So on this slide, again, some more statistics that you might already be aware of, but again, it's important to realize the impact. Most of us can probably come up with a plan to prevent falls with a cognitively intact patient that has good safety awareness, normal judgment, and attention. These patients are aware of the risks of falls. They will follow our recommendations to be cautious in order to avoid injury. But it's the 45 to 67% of our residents that have some sort of cognitive impairment where we struggle to prevent falls. And what we know is there's various levels of the cognitive impairment, but in nursing home residents, that is 45 to 67% that may have a diagnosis of dementia is either primary diagnosis or comorbidity. Evidence supports that the increased risk of falls in individuals, even in the early stages of dementia or mild cognitive impairment, and changes in gait, balance, and fear of falling can be related to increased fall risk. Some studies are showing that the use of exercise and other interventions can demonstrate some potential to reduce falls in this population. What we have to remember here is what's highlighted here is that few studies have strong designs to provide evidence for recommendations. That does not mean that there is no evidence. It's just that sometimes the studies have not been strong or well completed, but there's a lot of indications that that we can help prevent falls. So we know falls is a major safety concern for patients with dementia, but did you know that in addition to falling, serious injury is even more common? That 1/4 of dementia patients that fall sustain a fracture, which is 3 times more prevalent than fractures occurring after falls for non-cognitively impaired patients. In addition, statistics tell us that patients with dementia that fall have a poorer prognosis than cognitively normal elderly fallers, resulting in even more frequent hospitalization. So persons with dementia fall risk is 4 to 5 times greater, and we can ask why, and because they often have these changes that are listed on this slide. Changes in judgment and reason, recognition of sensory input, communication. Can the resident understand how to use a call bell? Can they actually accurately display or report the feelings that they have? If they have pain, often they result in behaviors versus them saying that they have pain. Are they able to initiate movement? The environment, are they able to adapt to it if it changes? So again, they get out of their routines. And their ability to retain any new memories becomes a limiting factor and can cause falls as well. Okay, so again, some risk factors for falling with dementia. They are more likely to experience problems with mobility, balance, and muscle weakness. They can have difficulties with their memory and finding their way around, can have difficulties processing what they see and reacting to situations. They may take medicines that make them drowsy, dizzy, or lower their blood pressure. They're at risk for feeling depressed and socially isolated. They may find it difficult to communicate their worries, needs, or feelings. Okay, so again, just to talk a little bit more about understanding the person behind the disease, there are some tools that we can use. And one of the important roles that Angela and I have within Aegis is using structured clinical programming to use a comprehensive and systematic approach in dealing with clinical needs. And as OTs, we are very sensitive to taking or tailoring our interventions in a way that is meaningful to our residents. So on this slide, we talk about some tools, again, going back to what's meaningful to our residents that are successful for practicing this purpose. The first tool is one of the tools is called the My Way tool. It's titled as an advanced directive, and there are some residents that are in the earlier stages that could fill it out themselves, but it can also be filled out with a family member or caregiver. These may be things that your social services director or nurses already ask, but this again provides a more comprehensive method to disseminate the information in a condensed way so that anyone that may come in contact with the resident has access to this information. Other tools are listed are the quality of life tool, the life story, the implications for fall management, and interest checklist. And the interest checklist, again, is knowing what the person did their whole life or enjoyed doing, and can take it to a level where we're again doing things that are meaningful and important to that resident. Okay, and with this point, I will turn it over to Angela.
All right, thanks, Kevin. Now we will discuss what we need to consider when developing that comprehensive program. And we really need to consider multiple items. Sometimes therapists get a referral to see a patient and they know a system or a particular symptom. Say, for example, muscle weakness, and they immediately go and they try to restore muscle strength. Another therapist may hear that the person had a cluttered room, and so their falls prevention intervention was environmental, making sure that the room was not cluttered. Now, in both cases, how successful are we going to be with preventing another fall? The odds are against us because falls are usually um, multifactorial. And therefore, we need to consider many things with falls prevention for each patient. Things we need to consider include the type of dementia, the stages of dementia, behavioral issues, their cognitive level, and many other things. And we will go over some of those things quickly today. The type of dementia is very important. And as you know, dementia is an umbrella term. There are many different types of dementia. And your falls prevention program may need to vary based on the type of dementia. For example, with Alzheimer's, typically you see issues with short-term memory first. And compare that to somebody that has Lewy bodies. With Lewy bodies, you typically see motor issues in the early stages. And so all these things need to be considered. Now, when we go to the next slide, we'll talk about the cognitive disabilities model. Now, with Aegis Therapies, we use this model a lot with our falls prevention management programming. And this is a model that was developed by Claudia Allen and OT. We really like this because it's a model for evaluation. You have your different tests to determine where a person is functioning cognitively. And also, this model has many resources or many books that suggest interventions based on the person's cognitive level. It's based on a hierarchy of cognitive processing, and it focuses on the person's strengths and what a person can do. And I really like it because it's a predictive assessment. A lot of times, therapists are asked, can this person live alone? With Allen testing, you can predict, can this person live alone? And what type of assistance will this person need so that they can live alone successfully? On the next slide, we have information on the 6 cognitive levels. Level 1 is advanced dementia. Level 6 is quote unquote normal. And hopefully we are all at a level 6 today. The thing that I love about this model, in addition to your levels, you actually have modes. There are 36 modes, and the modes are based on even numbers. For example, you have level 1.0, 1.2, 1.4, 1.5, and so forth. And so you do the specific testing to let you know specifically where this person is functioning from a cognitive perspective, and that gives you information for treatment planning. Something else that's very nice about this model is, and as you see on this slide, we have developmental age comparisons. And this is based on the theory of retrogenesis. That theory indicates that with dementia, you can compare it to normal development. However, we're going in the reverse direction. And so with the developmental age comparison, that gives you an idea of some potential safety issues and also some strategies in order to facilitate the best ability to function. Now, we do have these age comparisons, but I want to say this. We never treat a person with dementia like a child. They are adults. They have a risk history. We need to consider that risk history and their culture when we are doing program planning. But the developmental age comparison can help us with strategies. Now, on the next slide, we have a visual representation of level 1. This is your person with advanced dementia. A lot of times we think patients at this level are not capable of doing things and they're incapable of participating in programming. However, we do have some specific assessment tools, one that's called a sensory STEM assessment, to identify what these patients respond to. And we can set up sensory stimulation programs for them in order to facilitate um, them to be as active as possible. And please notice the red area, the field of conscious awareness. That shows you what the person pays attention to. Whenever you do any type of programming for a person at this level, you really need to be up close and personal. And their field of conscious awareness is really around the head and the neck area and so forth. Now let's proceed to looking at a visual representation of level 2. Now this shows a larger field of conscious awareness. However, it's still very limited. We have the area around the head and neck, and then we have the area around the legs. But notice the red only goes to the knees. That means that patients at this level and at level 2, typically patients are ambulatory. They do not notice barriers beneath their knees. And so think about that from a falls prevention perspective. If we have someone that's functioning at a level 2, we need to make sure that we do not have fall hazards below the knees, or the CNA or the care partner knows how to cue that person to avoid those barriers beneath the knees. Patients at level 2 typically like to do rhythmic things. They like to dance and that type of thing. They're not goal directed, but we can use that love of rhythmic movements to develop an exercise program to facilitate them to be strong and to maintain muscle strength. On the next slide, we have a visual representation of level 3. Now, the field of conscious awareness is greater. However, still they have tunnel vision. It's only approximately 14 inches. And so think of that from a falls prevention perspective. Now, this diagram, the person has on clothes, but notice that they're disheveled. They can do some basic ADLs, but they need constant cues to participate. The beautiful thing about this level, and this level is called manual actions, they love to utilize their hands. They can do things like stringing beads, putting tiles in a row, and that type of thing. They do, they're typically ambulatory, and sometimes they will walk and walk and walk. And we consider that a strength, and we want to maintain that ability. We need to make sure that they are walking in a safe environment and that they are monitored, because they do not recognize safety hazards. Sometimes we need to set up programming to facilitate them to take a rest, because they do become fatigued. And if they are fatigued, they are at a greater risk for falls. And so utilizing their love for manual actions, that needs to be incorporated in their falls prevention program. And let me give you an example of a patient that we actually had at one of our facilities. This person was admitted because of behavioral issues and also because of falls. She had lots of falls. So her husband admitted her to a skilled nursing facility. And the therapist asked the husband, what does she like to do? What are her interests? He said, well, she used to be a seamstress. She loves to sew, but she can't sew now. And so the occupational therapist gave her some material and visually showed her how to just ravel some of the material, just to manipulate it and to remove some of the threading. And the client automatically started doing this. So to her, she was sewing, but she really wasn't sewing. This became part of her falls prevention programs. Her husband indicated, well, gosh, I can take her home. If I can give her material and if she will take it apart, this gives me time to prepare dinner. And she was very happy doing this, and they were able to remove some of her psychotropic medication just with this one activity. Now let's look at level 4. And level 4 typically represents early dementia. You see this person is nicely dressed, and most patients function at a level 4, and we determine this through um, specific testing. They can do most of their ADLs. They may forget to do things like put on deodorant and that type of thing. Their field of conscious awareness is much larger, but they can still be at risk for falls because they don't pay attention to potential safety issues and and that type of thing. They are capable of new learning, and we can um, utilize some of that new learning to help with falls prevention. Okay, now let's go to the next slide and let's look at a visual representation of level 5. Uh, Level 5, we typically consider this mild cognitive impairment. Most patients at this level haven't been diagnosed, but a lot of times we as caregivers, we know that something's just not right? And we encourage you to refer these patients to therapy so that we can do specific cognitive testing so that we know exactly where they are. Typically, at this level, they are ambulatory, but they may not scan the environment completely. Also, they're not very good with problem solving. As you notice on the picture, it has the wording, shoes are killing him. He doesn't know to try a different pair of shoes and that type of thing. So typically, they need help to address potential safety issues. On the next slide, we have a visual representation of a level 6. Level 6 is normal. With level 6, that's called planned activities. We plan things and we structure things. We address safety issues and that type of thing. So now let's go on to the next slide and let's talk about some of the general things that we can do from a falls prevention standpoint. And today we're just presenting some of the basic information. We actually have a 4-hour course that we teach on falls prevention to the interdisciplinary team. And we provide specifics on falls prevention strategies for each of the 26 modes. But generally, you want to allow the resident extra time, especially residents that are and level 2 and 3. And if they're up walking, and if you give them directions, you want to keep the directions simple. You do want to give them extra time to process the directions. You want to do things like gain their attention first, say their name so that they know that you're speaking to them. You want to avoid pronouns. Patients that are functioning in the levels 1, 2, and 3 typically have difficulty understanding pronouns and understanding who you're talking about when you say I, they, me, or whatever, because they have to remember that and they have to associate it with whoever you're talking about. You want to reduce the noise in the room. You want to reduce the clutter. You want to be very consistent with the cueing that you provide. And so I suggest these patients being referred to therapy and the interdisciplinary team work out a falls prevention program together and we be very consistent with the cueing. We definitely need to be aware of the person's visual field and keep the person as active as possible. We want to keep them active as possible for 2 major reasons from a falls prevention standpoint. We want to make sure that we keep them strong. We want to maintain their balance. So we need to think about physical exercise in order to maintain strength and so forth and so forth. We also want to think about brain health. Some of the newest evidence indicates that when you do exercise, that facilitates oxygenation to the brain. And there's some schools of thought that indicate that that may slow down the cognitive deterioration by facilitating that exercise. But the exercise needs to be of moderate intensity in order to facilitate that oxygenation to the brain. Okay, let's go to the next slide. And the next slide has some information on safety and risk factors related to level 4 and 5. But remember earlier, I talked about the cognitive disabilities model and how we have the levels, but we also have the modes. Now, the resources indicate that 4.6 really is the lowest level that a person can live independently. Um, uh, and as you look at this slide says that anybody that's functioning below a 4.8, we need daily checks. Those daily checks are needed to help address potential safety issues in that type of 5. Say, if somebody's functioning at a higher level, such as 5.0 to 5.2, that client needs weekly checks. And just depending on the structure of the house and different things like that. Typically, like if somebody's functioning at a 4.6 and they're living alone, you really don't want them to be doing things like meal preparations. And so you may recommend things like Meals on Wheels. You would also recommend somebody to help them with financial management and that type of thing. But um, there's so many hints with this model to help you to set up a system to prevent falls and also to prevent rehospitalization. And as you all know, with payment reform, we definitely want to prevent those repeat visits to the hospital. Okay, next, go to the next slide. This slide has information on things that we can focus on if somebody's functioning at a level 4. Typically at a level 4, they're unaware of safety issues and they have difficulty following multiple step directions. And so when you give directions, you want to give them simple one step directions. Also, they may not attend to details such as locking brakes on the wheelchair. However, you can utilize different strategies to help compensate for them not paying attention to detail. For example, I was at one conference and they were talking about the Allen model. There was a patient who was functioning at a 4.0. The physical therapist was trying to get this person to lock their brakes consistently, and it just was not working. The occupational therapist evaluated this person and determined they were a 4.0. She looked in the Allen books. The Allen books indicated utilize striking visual cues. And so this OT decided, hey, I'm going to put yellow tape on the wheelchair brakes. And she taught the PT to cue that patient to touch the yellow brakes and to lock the yellow brakes. And they use very bright fluorescent tape for this. And the patient learned that. Patients at a 4.0 level are typical of some new learning, but it typically takes 2 to 3 weeks. And so after 2 to 3 weeks, this person was consistently locking their brakes, which was a great falls prevention strategy. Let's go to the next slide and let's focus a little bit on what we can do in SNFs to prevent falls. You know, a key thing is putting that walker in the same place consistently. Also, removing clutters, making sure that we have the appropriate wearing shoes when transferring or walking in a room. And let me just give you a little story about Mary. This is a true story. Mary had frequent falls. She had a walker, but the PT kept saying she was non-compliant. She did not use the walker. But this person has Alzheimer's. And remember, with Alzheimer's, you have memory problems. Uh, she was referred to speech, and they determined that she was a 4.4. And they decided, okay, she can learn new things. But what we need to do, we need to put her walker in a consistent place. And so they put color contrasting tape on the floor. and they put her walker near the head of the bed. They developed what they call the garage for her walker. So when she woke up in the morning, the walker was there. The walker was a visual cue to help remind her to always use that walker. And the whole staff knew to always to put her walker back in its garage so that she will know to use this walker consistently. Okay, let's go to the next slide. And on the next slide, we're going to talk a little bit about level threes. Now remember, level threes, they have tunnel vision. Typically, they cognitively process 14 inches or less, but they love to use their hands. However, they may not initiate activity. We may have to initiate that activity for them. A safe place for walking is so important. They do like to walk. Um, and we consider that a strength, but let's make sure it's safe. Okay. Um, let's go to the next slide. And these are some of the safety risk factors that may be appropriate for somebody that's a level three. Sometimes providing physical barriers to keep them from going in some areas that are unsafe, or providing alarms to help to prevent them from getting lost. Patients that are living in the community, or sometimes people are utilizing GPS or tracking devices just in case that person leaves home. We definitely want to have a way to find them. Striking visual cues help. Also help. They typically need help with problem solving and so forth. So let's go to the next slide. Um, so key points with middle stage, um, what you can do to reduce falls. Again, allowing extra time, being consistent in your communication. If you have to repeat something, repeat it the same way. If you say it a different way, the person with dementia may think you're asking them to do something different. A toileting schedule is so important. These patients are typically able to be continent, but sometimes they rush to the toilet. And there are many accidents in relationship to toileting. So develop that schedule and stick to it. And that schedule should be based on that person's history. I recommend utilizing a bladder diary to determine the person's patterns from a toileting perspective. The toileting every 2 hours typically doesn't work. You want that toileting program to be based on that person's. Cue that person to slow down and take their time. A lot of times they're in a hurry when they walk. And that may um, cause falls. A lot of times in the middle stage, sometimes they're at risk for behavioral issues. You want to try to minimize those behavioral issues and develop behavior management programs, and that's another key strategy for preventing falls. And remember the tunnel vision. They need intermittent cueing throughout tasks. Let's go to the next slide. Um, just a little bit on late stage or level two. Um, a lot of times they're seeking comfort. They like rocking movement. And so if you have a rocking chair, that's a great falls prevention strategy. They sit in that rocking chair, it's comforting to them. Also, when they use the rocking chair, they are exercising their legs. Okay, remember their visual field is very limited. And typically patients that are functioning above a 2.4 are ambulatory. We do want to keep them walking safely. Let's go to the next slide. I do want to mention one thing about 2.8. Patients that are functioning at a 2.8, a lot of times they utilize a gross grasp. We call it a death grip. Sometimes people see that as a problem. However, We can teach the CNAs and family members how to use that death grip functionally for that patient that's functioning at the 2.2 level. Okay? Now, regarding late stage dementia, a lot of times they are wandering, and so we want to make sure that they are safe. Um, so let's go to the next slide, Kevin. Things that you can do, you can ask yes no questions to allow the person at this stage to communicate their needs. Trying a rocking chair is wonderful. Using a gait belt, as I indicated before, they typically have that death grip. So setting up systems so that they can utilize grab bars, that's a wonderful thing for patients at this level. Okay, next slide. Now, with advanced stages, a lot of times with advanced stages, these patients are not ambulatory. And so we definitely want to have a positioning program, and we want to adhere to that positioning program to facilitate proper body alignment, because we want to make sure we minimize the potential for falls from the wheelchair. Also, we want a bed positioning program. We want to minimize the opportunities for falls from the bed. One other thing that I did not mention that I want to mention, that if somebody is functioning at a level 2.0 through 2.2, a lot of times that person is treated as a dependent transfer. But we can utilize 1, 2, 3, go. We show that patient where we want them to transfer to, and we utilize 1, 2, 3 in order to get them to participate more in the transfer. Okay, now let's go to the next slide. These are just some basic things that you can do. Let's try to minimize behavioral issues. And remember, a lot of times we cause behavioral issues. We can't change that person with dementia, but we can change our approach. We also want to try to get into their world. We want to try to find out their interests and utilize their interests as much as possible with programming. Okay, next slide. This is just a little bit on a behavioral analysis. If somebody has a behavioral issue, we want to think about what's the fuel, what's the match, and what's the consequence. We want to think about the ABCs of the behavioral issue. And I encourage you to work with your therapist, and you all work together as a team to address some of the behavioral issues. And behavioral issues definitely can cause falls. And on the next slide, we talk a little bit about a team approach from a falls prevention perspective. We have what we call a collaborative FMP, and it's a 10-day protocol. And the therapists determine the person's cognitive level, but we work hand in hand with the CNA and the family members and nursing and activities to develop that falls prevention program. And on the next slide, we've got information on low vision and falls management. But this slide has a little bit of information on some of the typical changes you see with the aging eye. These can contribute to falls. Now, in addition, on the next slide, we have some information on some of the disease processes that we sometimes see in skilled nursing facilities. And the evidence indicates that 1 in 4 patients in skilled nursing facilities have age-related visual dysfunction. And so we need to know about this, and we need to know some of the implications related to the visual dysfunction. On the next slide, we've got information on macular degeneration. Macular degeneration, that's a very prevalent type of visual dysfunction in skilled nursing facilities. And with that, we typically see a central vision loss. With diabetic retinopathy, because of the diabetes, we also have patients with diabetic retinopathy. They typically have spotty vision. On the next slide, we see information on glaucoma. A patient with glaucoma typically has decreased peripheral vision, and glaucoma typically has the most profound impact on falls just because they aren't seeing things from the side. And so we need to cue them about things from the side. Also do specific testing to determine their peripheral vision. And your occupational therapist can help you with that. With cataracts, we don't see cataracts as much now because of cataract surgery. But with cataracts, typically you have general blurring. On the next slide, we have some information on falls management strategies for low vision. Enhanced lighting, that's a big thing. Uh, you can use a light meter to determine if the lighting is adequate, and you don't even have to buy an expensive light meter. They have different apps. You want to reduce glare and increase contrast, utilize color. You don't have to spend a lot of money to increase contrast. For example, if you have a bed uh, that's beige and the wall is beige, you can put a blanket on the bed, a colorful blanket to create contrast. You can also anchor furniture in order to reduce falls. You want to utilize optical aids. For example, you can buy filters to help reduce glare for your patients. Um, all types of environmental modifications, and the environmental modifications do not have to be costly. You can install a black toilet seat so that that person can easily identify the toilet. So we won't have falls related to toileting issues. I do want to encourage regular eye exams for patients with low vision. And please utilize specialists. If the person has macular degeneration, make sure they are seen by a retinal specialist. If the person has glaucoma, make sure they are seen by a glaucoma specialist. Maybe 10 years ago, I was told that I had macular degeneration by a ophthalmologist. And my neighbor who had macular degeneration told me, she says, you need to go to a retina specialist. When I went to that retina specialist told me, no, you don't have macular degeneration. I want you to do X, Y, Z. So it's really important to go to the right doctor. Okay? And on our next slide, Kevin is going to talk about falls prevention FMPs.
Okay. All right. Thanks, Angela. Okay, so we're going to talk a little bit more about that transdisciplinary approach that we mentioned earlier. This slide just sort of gives you a little visual diagram about the client and the family being at the center, all of our disciplines coming out in different areas that we can address. So one of the things I would want you to consider is really the evolution of a transdisciplinary team. And so let's just quickly talk about each of these areas. So the unidisciplinary level is really where our teams are working in a silo, where we're very good about, like for therapy, we're looking at the therapeutic needs, and that's it. Nursing, we're doing a good job of nursing, but we're not really integrating and coordinating with the other disciplines. The next one is the multidisciplinary level, and this is where I consider the referral level. This is where something happens and we refer to another discipline, and that's really what we do. There's not a lot of coordination, whatnot, so a patient falls, nursing might say, okay, we're going to referral PT. Okay, and then if they follow up later, nursing does their own things, but PT does their own things, and again, still not a lot of coordination. The next one is when we transition a little bit further to more of a collaborative approach, interdisciplinary, where we're working with other disciplines, but at the end of the day, we're still sort of assuming the responsibility for our own discipline or within our own discipline. And so I would imagine most of our teams, if you guys are on the call, are probably at the multidisciplinary or interdisciplinary levels. Where we really want to try to focus is getting to the transdisciplinary. This is really where there's no boundaries between the disciplines, when we're sort of all working together for a common goal. Really truly understanding the value that each member of the team can bring. Okay. So the next slide talks about putting this team together. And so we'll go through all these as we go through, as we're getting tight on time already. It's a lot of information for an hour, but these are members of your falls management team: nursing, therapy, recreation service director, social services, maintenance, housekeeping. Family is to be part of this team: restorative, dietary, admissions, and CNAs. So the falls management team, or the falls prevention team, is designed to use that transdisciplinary approach to management in the long-term care facilities. The purpose of the team is to prevent falls, identify reasons for the falls, facilitate implementation of prevention strategies, ultimately to reduce falls, and to serve as a way to educate our facility team, residents, and/or the caregivers. So getting started is, we really want to talk about selecting 3 program champions, one from nursing, one from rehab, and the recreation services director. The team really is completing assessments for analysis, and they want to develop some specific items to consider, and there is a list of them. Quickly to just mention some of the big ones: the environmental analysis and modification, medication analysis, looking at the environment. Are there a walk to dine program, referrals to therapy? There's so many areas that we can do that we just want to make sure that we're considering all that. And again, we don't have time to go through every single one, but there, again, it's a really consistent approach, and it might be dependent on your facility of what areas you need to address. But one of the things we talk about is the program champion, and that is really a starting point, because the program champion can help develop those facility systems in conjunction with the administrator and the director of nursing, providing education to the team, whether it's the falls team or the whole facility team itself. Participate in the falls prevention meetings, so we want the program champions in those meetings. We want to have the program champions help coordinate the program by taking ownership of the program, and then also tracking success. What is improving, what is working, and I always wanted to go back and look at the data and what we can do from that. So integration of nursing, therapy, and recreation service director. So the first thing is, again, to get out of that unidisciplinary or that more siloed approach, we want to be sharing all of our assessment results. Rehab does so going back to some of the things Angela shared, was that rehab can do the cognitive assessment, get that level. And then that level can have impact on how nursing and recreation or activities can interact with the patient. So the nurse may do a medical assessment that then lets the other disciplines know about risk factors, such as if the patient has glaucoma. If the patient does have glaucoma, then that can be sent to OT, and with that information, the OT can develop an optimal restorative program. OT and nursing then can work together to develop an effective ADL routine to reduce falls. And then therapy can also work with recreation and develop an activity-based program geared to reducing falls as well. Steps to follow. So again, just talking about these, and we'll go through these in the next following slides. Did want to mention a little bit about fall prevention movement patterns. And so this is just an example of what can be done to help prevent falls. This is an example. A lot of our patients have that look where their head is down, their shoulders are rounded. What that does is reduces their awareness of the environment, so not noticing what's going on. Also, their center of gravity can become forward. So in this example, we might have a physical therapist that look at a resident and determines that the look up and reach up movement pattern would be beneficial. So they can develop a program based to work on to increasing their balance and strength. Once the particular pattern has been identified, then PT can train the activity staff on types of activities that can be done to include the patient in on a consistent basis, so that the patient can perform these patterns daily as part of their exercise and falls prevention program. So for example, if the PT identifies that the look up and reach up strategy is a pattern that a particular resident could use or benefit from, then the PT can train activities to use certain things like balloon toss, or training the housekeeping to put his clean clothes on the top shelf in the closet, so he has to look up and reach up to get his clothes every day. So again, involving all disciplines. And we don't always think about housekeeping and maintenance, but they are also vital parts of the team when it comes to fall reduction. For nursing, so let's start with the program champion. Provides the assistance with developing facility systems. They participate in the fall prevention meetings, provides training to rehab, to CNAs and recreation as well, and they monitor compliance and success of the program. Nursing completes the analysis and assessment of the fall, the review of the medical symptoms, looking at things such as sleep habits and daily routines, the toileting program Angela had mentioned, consideration of falls-related trends, developing the care plan, and providing that ongoing education for patient, staff, and family. The CNA is very important, as they have a lot of the most direct contact with the residents. So we need them to report changes in condition that may impact falls. That can be a very proactive approach if they start seeing things that, the person starts becoming a little bit wobbly. So before they fall, that information is shared with the rest of the team. Following the functional maintenance program developed by therapy, working with the therapist to develop an optimal program. Social services and missions. We want to make sure that we get the information about that client or that resident. What was their history? Did they have falls? Getting this information and communicating it to the rest of the team before the patient or the resident is even admitted can help reduce the falls before they even get there. Restorative. That's a term that's sort of different from every facility to facility, but it's how we implement it, whether we have dedicated restorative nursing or we have our CNAs providing it. But restorative programs can help prevent falls, and they really need to include more than just ambulation. So again, looking at movement patterns, what can be done to reduce falls in that way. Rehab obviously has a big role in this. Also should be a program champion for therapy. And then really all three disciplines should be involved. And I think that, in some of our settings, nursing refers PT pretty commonly, but as Angela shared, with the vision aspect, that's an area where OT is very strong at. And then cognition, OT and speech are very strong on that. So if the falls are related not because of strength and weakness, those are areas that we want to make sure that are being addressed by the whole team. So, our approach is really to provide clinical training to our staff. We have programs such as the balance management program, low vision, dementia courses that really can help guide this therapist on assessment tools and interventions that have evidence behind them. So we're not just trying things, we're actually following what the research shows. Additionally, we also want to ensure that our staff are able to demonstrate competencies in these areas. Okay, to the top of the hour, so I'll quickly go through program application. We're always looking at reviewing the program and looking at the data. We want to make sure that that we're getting the data, the input that from the rest of the team that we're doing, and we want to make sure that the falls, if they're happening, again, what's the cause of them? We also make sure that we're developing those effective methods to communicate strategies to all staff as needed. The fall prevention team should really meet 3 to 5 times per week. The frequency really will depend on the size of the facility and how many admissions that we're getting on a consistent basis. But again, always should be looking at this data. The meeting after initial implementation should be pretty brief, should not have to be hours upon hours. Getting it started might take some time, but the investment should definitely pay off in the future. There's a list of treatment plan items for consideration, environmental analysis. These will be part of a handout that you will have access to. Again, for the sake of time, we'll just sort of scoot through here. Definitely want to make sure we're screening residents timely. So we know we do this usually on admission and quarterly. These are one areas, but also we want to make sure our staff, our nursing staff, our day-to-day hands-on staff are providing information proactively if we start seeing that the resident's showing some cognition deficits, some visual deficits, their continence levels changing. Any of these areas listed here would be things that we can definitely capture on their quarterly screens, but we want to try to catch them even before that happens. Definitely, need to care plan, looking at residents at high and medium risk. We want to look at a post-fall assessment. So we want to take the consideration of the time of day, the location, what was going on, were there behaviors involved, is it proper footwear? Restraints are much more limited than they ever were, but do we still have them? Did that contribute to the fall, or was there a positioning device that contributed to a fall? Okay. This slide is a diagram, just talks about poor sitting posture, can give you reasons why. Lethargy, kyphosis, poor sitting balance, and then again, it sort of leads you into what could be possible causes of medication. Is there a diagnosis-related issue? And again, what can be approached based on that? Same thing with falls, same idea here, looking at different factors, who can be causes for them, and again, what could be intervention strategies from them. As we close up here, facility analysis, again, just looking at the fall event location, so where did it occur, and getting a really good description, because that information will help us when it comes to preventing further falls. Okay, we're a couple minutes past the hour, so I want to thank you guys for hanging in there. Again, a lot of information and really, and so thankful that you guys joined us today. Again, we will be presenting, we're offering a couple resources, including this handout. We also will have an Excel spreadsheet that gives you some more strategies to help reduce falls. So Wendy, I'll turn it back over to you.
Great. Thank you, Angela and Kevin. That was really great information that you presented today. At this time, we're going to open up the question and answer portion. So please use your questions box on the right hand of your screen if you have any questions for Angela and Kevin. And know that I will be sending out before the end of the business day today an email with Angela and Kevin's contact information and the handouts that Kevin just mentioned. So those resources are available, will be made available to you later today. And their contact information will also be made available so that if you do think of any questions or need to contact them as you run into situations in your facilities, you can reach out to them at any time. We'll give it another 30 seconds or so. I don't see any questions at this time. I think you guys did a great job covering everything today.
Thanks, Wendy. And again, just as a follow-up again, is like there was just so much information. And as Angela said, we have such long trainings and whatnot. So hopefully this at least gets us started to think. And again, and as Wendy said, if you have any questions, please feel free to reach out to us. And if there's anything we can do, we will definitely help you with that.
Great.
And just in closing, falls management, falls prevention, it can be a reality if we utilize a comprehensive transdisciplinary approach.
Great. All right. Again, I'll be emailing the survey later today along with the other information. So please take a moment to provide your feedback. It is important to us. And I just want to thank Kevin and Angela again. It was great information. Hopefully we can have them back for other trainings and convention or other PHCA training events. I thought that was really great information that they shared, and I'm sure there's a lot more to it, as they said. So at this time, we're going to close the webinar, and I just want to wish everyone a great remainder to your day.